Prasad, Dr. Jay Prakash, for having invited me today to speak on this subject. Management of intracapsular fractures, neck of femur, non-union. This is my technique. We come into this world through the brim of the pelvis and exit through the neck of the femur. The history is that McMurray described an osteotomy for ununited fractures of the femoral neck in 1936, formerly used by Haas in 1922, where the femur is placed medially beneath the femoral head following an oblique osteotomy. In 1940, Anderson used vascular fibular graft for fixation, but King combined this with an SP nail, and in 1962, Jude advocated the use of vascularized bone graft into the posterior aspect of the neck of the femur and fixed it with screws. Ledbetter modified this technique in 1944, and all the osteotomies and fixations with various devices described since then are below the neck of the femur, giving an armchair effect such as that. Transfracture abduction osteotomy was originally started by me as a solution for non-union of fracture neck of femur in children. When it proved successful, I extended this option to even adults. Now, for example, here's an example of a young boy of 12 years old with a non-union and badly fixed. You see, you should never have the screws crossing the fracture site, and there is rotation at the fracture. And this, we've done the transfracture abduction osteotomy, which I will show you the technique as we go on. 6 weeks post-op. This is 7 months post-op, and this is 8 months post-op, and this is 20 years post-op. You see the patient is grown to an adult, and he came to us. I don't think this video is working. There's not. Anyway, they didn't pull this in. Anyway, it walks nicely, so I can't. TFAO defeats the attitude that has long been held by medical and lay persons towards the management of non-union of intracapsular fracture neck of femur. In TFAO, osteoconduction is introduced directly into the non-union site, unlike other osteotomies described where the osteotomy is performed below the neck of the femur. Preoperative planning is important, and the goal of this reconstructive surgery is restoration of normal anatomy, which is accepted to be mechanically optimal for function. A simple technique of post-op preoperative drawings is important, and tracings are used to arrive at the desired biomechanical solution. Now, this is to show you how it's done. The patient is on the fracture table with the hip in adduction with traction. The trochanter is pulled down as far as possible, and then 2 pins are inserted into the superior part of the neck of the femur through the trochanter. And then an osteotomy is performed with the base of a wedge laterally in that fashion, and the bone is removed and then put through the osteotomy into the neck of the femur after curating it, and then a 3rd pin is passed parallel to the lower osteotomy up to the neck of femur. Then the lower part is abducted and brought into position, and you got the neck shaft angle restored. Then you pass the 3rd pin into the head of the femur, which keeps the osteotomy closed, and a 4th pin goes in, and that is how it looks at the end of it. This is just a case demonstration on the table I wanted to show you. It's a young boy of 10 years, and he was diagnosed as a sequel of chronic osteomyelitis, and he had shortening and limp. And here you see that is the neck of the femur, and there is a sequestrum. You can see the arrow there, the sequestrum, but he had never any discharge of pus inside. So this is the situation with which he came. Well, anyway, none of these videos work. So TFAO was done for him, and this is the technique. You see the superior pin is passed, the Moore's pin is passed in and such, and the hip is in adduction, and that is a lateral view of the same. Then 2 pins parallel to one another, and you see the 2 pins, you can't see them now. And then the power saw is being used here to cut the wedge of bone into the fracture site. And you see the two osteotomes, one on either side, on either side of the osteotomy. And then that bone is then removed and curated inside the neck of the femur. And we used a little drill there also and curate. And bone has been taken out from the osteotomy and put into a bowl there, and that is inserted inside the neck of femur, and the osteotomy is closed. See, the osteoconduction is directly into the fracture site along the osteotomy. And the third pin is then inserted, and then the fourth pin. And this is on the table. Once you put the bottom pins, the osteotomy remains closed. But however, we put circular wires with stainless steel, as you can see there, stainless steel wire, to keep the osteotomy closed. And that is him at 2 months, 3 months, 2 months. All patients are in hip spica for 8 weeks in all my cases. And that's 5 months. And that's the patient. He walks well with a very minimal limp now. This is now just a few examples. This is a 20-year-old boy with a 10 years non-union, 10 years, walking with that gait. This is an osteotomy, and unfortunately in this case, the osteotomy opened up in a month when he came for a checkup, and I went back in and I redid it in the sense I put in cancellous screws and wired it at 9 weeks, and you see him at 4 months, fracture united there. This is a bone scan of that. There is shortening in this patient, of course. This is an 8-year-old child. This is my first patient, and she had this fracture, and we just planned that at the time, and in that time I used a cross pin, which I don't do now. And when we removed one pin, that is her at one year post-op. Well united. We lost contact with that patient subsequently. This is a 4 years non-union in a young girl of 15 years. And this is the same situation she had. And then 3 months post-op, then the pin started to extrude, so I took the pins out. I went in and just put cancellous screws to keep the fracture in position. And that's 1 year post-op. And this is 15 years post-op, same patient. And that is her, and she walks absolutely normal. I'm very sorry the videos don't work here. She can squat fully. This is a 16-year-old boy, 6 months non-union, operated elsewhere, and it did not unite. So we did a transfracture osteotomy. This is 2 years post-op. And this is the patient 18 years post-op with 2 inches of shortening. This is bone scan. This is a 10 months non-union for a failed fixation. And this is him at 1 year, 2 months, 5 years, 11 years post-op now. And I got his video yesterday, but it doesn't work. He's in Pune, so he sent me the video yesterday. So it's now almost 16 years now. This is a case of 1974, 1 year non-union due to fracture shaft of femur, missed neck of femur. We have about 4 cases like that. Always take the X-ray of the entire bone because you will miss the neck of the femur. So this is her after the osteotomy, and this is her 25 years after osteotomy. And again, she walks well, but my videos don't work here. This is a non-union 6 months. In Saudi, I did this case. Krishna Reddy was also involved with this. And you see him at 5 months. This patient went home. He's an Arab. He went home with a hip spica. He walked on it, and he went home and removed it. And it was without the hip spica he united. This is a 30-year-old lady, again, poorly fixed. 6 months non-union, converted. This is at 3 years. United. 2 months non-union. This is the shortest non-union I did, and went on 7 months post-op and went on to good union. That is 5 years post-op, the same case. This is a 40-year-old at 1 year non-union. This is a transfracture osteotomy. And there it is at 1 year and at 2 years after the pins were removed. Looks like AVN, but no pain. None of these patients had pain, even though they pictures. This is another 2 years old non-union. 1986 I did this. He was a fracture of shaft of femur also, missed again. And this is him. You can see that the head is completely rotated, and in spite of that, it united. And that is him at 3 years post-op, and this is him 26 years post-op. And you see him, and he walks, he bends, does everything, except he's got a little movement is short of 90 degrees, and he walks fairly well. This is a 10-year post-op case, and he walked in the other day, 35 years after his operation, and I took his x-rays, and that's how it looks, and he walks without a limp. 4 years post-op. You see the neck shaft angle is restored. It looks like a normal hip. There is no armchair effect in these cases because the osteotomy is performed high up into the fracture site. This is a failed SP nail, 4 years post-op. This is non-union at 4 years. And Dr. Padmarao sent me this case, in fact, and this is 86, and here he is at immediate post-op, 4 years post-op. See that? And this is a failed DHS, 10 months, 21 months post-op, and 11 years. This is 11 years post-op, another case. And that is, this is another case of 5 months post-op, and then 11.5 years post-op. So we have good follow-up on these cases. 11 years post-op, this is another case. That's him, he came in, I did that in NIMS, and he came for removal of those pins, and that's the range of motion. This is after, again, 7 years post-op. So all these cases, we have results were that we had a total number of 30, we've added another 5, and females were 12, 18 males. Age distribution maximum was in the 3rd decade, and non-union period, the minimum was 2 months and the maximum was 10 years, both of which I showed you, and the minimum follow-up was 2 years and up to 35 years now. Advantages of TFAO over muscle pedicle is that there is minimal soft tissue dissection, less operating time, the anterior and the posterior capsules are not touched, and the hip stiffness is avoided, because all these patients have good hip range. Advantages of our total hip, of course, is that the patient has his own femoral head and neck, and the cost-benefit ratio, longevity, and in young children, what else would you do? Non-union and AVN of the femoral head have nevertheless remained as one of the major complications following fracture neck of femur, which ranges from 10 to 20% in spite of modern modalities of management. In these cases, all consecutive cases, we achieved 100% union rate, near normal range of movements, and by this procedure, the neck shaft angle is restored and union is achieved. This procedure requires a high degree of cooperation because of hip spica for 8 weeks. Careful preoperative assessment of the patient's psychological and socio-economic status is mandatory. I published this in the Indian Journal of Orthopedics as an original article in 2014. It has been printed in the IJO. Thank you.
Thank you very much, sir, for your excellent topic.